Good afternoon, everyone, and thank you for joining me today on our Transitioning from FIG to FHO webinar. My name is Josh, and I will be taking you through the presentation today. We have a wonderful presentation, lots of people logged on, so that's great. Hopefully everyone will find it to be very informative, and we'll be able to help you better understand what it means to transition from the FIG to the FHO model. So let's go ahead and get started. And if you do have any questions throughout the presentation, I ask that you please write them down, and then you can email me or give me a call after the presentation is completed. So let's go ahead and get started. So a little bit about Cirrus for the new members joining us today. We were founded back in 1994. We have about 50 employees, and we're headquartered in Toronto. Cirrus is really comprised of two specialized models, one being office lease negotiations, which we do over 500 per year, and then the part that I'll be speaking to today is the healthcare consulting, making sure that our physicians have billing support and operational support to better assist them in running their practice, both on the group and individual level. So some quick facts. Family physicians today are now better compensated in Ontario than anywhere else in Canada. More than 75% of all physicians say their pay does not align with the care they deliver. So that means that a lot of physicians are providing the comprehensive care to all their patients, bringing them in when necessary, seeing them after hours, seeing them for home visits, etc., but not necessarily being paid for what they're doing. The majority of the province are still practicing in the FHO model. Ontario physicians are generally not strategic in how they are paid due to a widespread lack of clarity around OHIP funding models. Now, the FHO model is your friend, but it can also be complicated at times and a little confusing. And that's where we come into play, helping you better understand what exactly it means to be in the FHO model, how to properly bill for the services you are providing, and making sure that everything does align properly, making sure that you have that work-life balance as well as the income for the care you're providing. So the purpose of today's program is to increase your understanding of the FHO model, a comparison of the FIG versus FHO, and of course to leave you with a much clearer picture of what the FHO is all about and how to go about transitioning. So why was the FHO introduced? So back in the 90s, there was an increasing age in population. There was a lot of urgent care facilities in high use. There was a focus more on treating the patient after the case rather than preventing it. And a lot of people were really thinking about how many patients can I really see in a day? Can I see 50? Can I see 60? Can I see 70? Trying to push through as many as you possibly can, rather than only bringing in those that are medically necessary. There was also only 1 in 5 physicians were accepting new patients, so very few family doctors were accepting new patients because they felt that they were at their max capacity. As well, back in 2002, 1 million Ontario residents were without a family doctor. And by 2010, estimated 2 million were without a family doctor, or as we call them, orphan patients. And of course, fewer new family medicine graduates. However, those numbers are changing for the better as we move into mid-2014 and pushing towards 2015. So, based on what we've seen from the early 2000s up until now, there is a rise on patient accessibility. That whole FHO model is about providing access to your patients. Having open spots during the day so they can call in the morning and come see you. Children get sick overnight. The parent calls in the morning. My child has X, Y, and Z. I need to come see you. Now the patients have that ability. The physicians are leaving those spots open, and they have the time to have those patients come in when it's necessary for them to come in. So what exactly is the FHO model? So the FHO model is a payment model whereby physicians get paid a monthly payment for every patient they have on their roster, regardless of whether they've seen that patient or not. Whereas it used to be that you were paid for each encounter. As in the fee-for-service world, every time a patient comes through the door, you swipe their health card, you're getting paid for every encounter. Whereas now, we don't necessarily have to bring in all the patients. we want only those that are medically necessary to come through the door. And the ones that don't come through the door, we still receive a payment, a yearly payment that obviously is broken down monthly. So again, rather than being compensated on volume, seeing those 60, 70 patients a day, we're really focusing on those medically necessary visits, the preventive care and the complex care. Bottom line is throughput versus access. We're no longer looking to have a revolving door, but rather providing access to the patients that require it. So a little comparison of the FHG and FHO model. So in the FHG model, the fixed payments that you're going to be receiving are from your comprehensive care payment, and that's having patients rostered to you. It's about $35 approximately on average per month. Sorry, per year per physician, per patient. Now, in the FHO model, you receive that comprehensive care payment, but you're also receiving a base rate payment, which is quite significant, give or take about $160 per year per patient. Performance-based incentives. Now, in the FHG model and the FHO model, you're still receiving your fee-for-service billings, you're still receiving your patient enrollment incentives, you're still receiving your preventive care bonuses. Where it changes slightly is your special premiums now go to 8. You're now receiving in the FHO model an access bonus, you're now receiving shadow billing, and you now have an opportunity to receive CME credits. And we'll get to speaking about these as we go through. Keep this in mind, between approximately 70 to 77% of all income in the FHO model is fixed. Now that is coming from your comprehensive care payment and your base rate payment. Together we call it a capitation payment. So here you can see an illustrative breakdown of what it looks like FHG to FHO comparison, whereas your fixed income is quite small in the FHG model, whereas it's quite large in the FHO. So that's allowing you to have that predictability every month, knowing that, even if you go on vacation or if you see a few less patients, you still have that guaranteed fixed income on a monthly basis coming in. Now, an average Cirrus client income increases by about 18% when transitioning to the FHO model. Now, we always talk about the income being, predictable and everything like that, but you're also looking at the work-life balance that you have when you transition to the FHO model. It allows you to have a more relaxed atmosphere, so to speak, seeing those patients that are only medically necessary, not having to bring in patients just to have ends meet. It really is that work-life balance that we're trying to establish for you guys, and making sure that you are being obviously compensated for the care that you're providing. So let's talk about a little FHO education. So here you can see an illustrative of the 6 different income streams that are available in the FHO model. Your capitation payments, obviously related to your roster, fee-for-service billings, how many patients you're seeing on a given day, net access bonus, which also can be referred to as outside use, making sure that your patients are not going to walk-in clinics. Shadow billing is a 15% premium on all in-basket services that you'll be providing to your rostered patients. Again, we'll discuss a little bit more. Preventive care bonuses, same as in the FHG model, your $12,800 available across those 5 categories. And then your special premiums. Now in the FHO model, there's 8 different categories and $37,000 available across those 8 categories. So capitation payments in the FHO. So as I said earlier, it's a monthly payment that's provided for each rostered patient and is adjusted based on the age and sex of a patient. You're essentially being prepaid to cover 126 fee codes that are considered in-basket. That's your standard care that you're going to be providing to your patients, such as your A007s. Any other services that's not part of that 126 is considered out of basket, and you'll receive the full 100% value of those codes, for example, diabetic care. Now, keep in mind for the FHG physicians logging on today, you are able to take advantage of the guaranteed income available, as I said, through the comprehensive care payment at about $35 per rostered patient per year. Now, it doesn't seem like a lot, but it does add up. as you can see here, 500 patients is $17,500 of guaranteed income every year. And if you had up to 2,000 patients, about $70,000 of guaranteed income every year. So here you can see a breakdown of how you'll be paid per patient. Across the bottom, you'll see the age categories, and across the left side, you'll see how much the patient is worth. So the patients start out when they're born at about $175 per year. They'll drop down slightly. Females will start to rise again at the age of about 14, and males not again till about the age of 30. Now, as you can see, it goes up quite high as you age. So, an 80-year-old female is going to be worth quite a lot more than, let's say, a 19-year-old male. So, although it is, necessary to have a nice range of patients across your roster, if you are looking to generate more income, obviously taking on more elderly patients is a great way to do that. So what does fixed income give you? Obviously predictability, as I've said, increased flexibility as well, making, you know that you're having that income come in on a monthly basis. You don't have to worry about not taking a vacation or not seeing enough patients on a given day. Helps you to mitigate against peaks and valleys. We've done a number of FIG to FHO income analyses where we take the FIG information from your RAs and we show you what your life would look like with that roster size in the FHO model based on the age and sex breakdown. Now, we've seen clients come to us and they have, in the last 6 months, they've earned anywhere from $10,000 to $25,000. Now, that's a very wide range, and having those peaks and valleys can be nerve-wracking at times. If they have $11,000 coming in 1 month and then $18,000 the next month and $14,000 the next month and $22,000 the next month, there's some volatility there, and we don't like to see that. We want to see it smooth across the board, if not increasing every month. Now, you can see by the number of patients having rostered, anywhere from 600 patients of $129,000 guaranteed income to 2,400 patients and $516,000 income. So having the right roster size for you is extremely important, and that's something that we definitely help with along the way. It also eases the pain during large transitions. So, for example, if you're making that transition to an EMR and there's going to be a few days in the week where you're not going to be able to see patients, the computers are down for maintenance, and you're upgrading your systems and everything like that, you just can't open the office, you'll still be getting paid that monthly payment for all the patients that you have rostered. So you don't have to worry as much. Now, Cirrus ensures that your roster is properly managed. Now, we'll go through it at the beginning, we'll go through it at the middle, we'll go through it at the end. We always want to make sure that your roster is optimized because in the FHO model, it's your greatest income generator. So let's speak about fee-for-service billings now. So at the high level, we can separate into enrolled patients and non-enrolled patients. Let's first speak about enrolled patients on the left side. Now, we spoke earlier about the in-basket services. That's your 126 fee codes that you're essentially being prepaid for with your capitation payments. Now, every time you see a patient for an in-basket service, you'll receive 15% value on top of whatever the value is. So, for example, in A007, you'll receive about just over $5 worth every time you see that patient, in addition to your capitation payments. Now, any out-of-basket service, you will receive the full fee-for-service value. So again, any codes that are out of basket, so your diabetic codes, you will receive the full value of those codes. Now, if you move over to the non-enrolled patients, there's both in-basket and out-of-basket services for those patients. Now, any in-basket service, you will get the full fee-for-service value because they're not enrolled, although their group is subject to a hard cap of about $60,000 per patient pooled together on the group level. So if you have 10 physicians at $60,000 each, that's $600,000 that you're able to spend as a group on in-basket services to non-enrolled patients. Now, we've never seen anyone come close to this except when you're running a walk-in clinic as well. Now, many of you don't do that, so it's not something to worry about. But again, if it is something that you're concerned about, we'd be happy to look into more detail about your practice specifically and give you some more information about that. And then, of course, out-of-basket services will be paid at the full fee-for-service value as well. Now, also keep in mind that there is no hard cap in the first year of practice in the FHO model. With that being said, we want to make sure that we don't get to that level. So when you do transition to the FHO model, the ministry does give you that leeway of 1 year to make sure that you're rostering the right patients. And they do give you that opportunity by allowing you to bill in-basket services for non-enrolled patients, just to make sure you get that roster composition right during that first year. So some out-of-basket services. Here you'll see our FHO practice billing guide. We call it a cheat sheet. These are the common out-of-basket codes. Now, we provide this to all of our clients, and it's a handy guide to keep around when you're doing your billings to make sure that you do submit those out-of-basket codes so you are getting the full fee-for-service value. Some of the key areas are diabetes management, smoking cessation, and of course after-hours billing. So as I said earlier, diabetes management, one of our out-of-basket areas, very commonly billed across most practices. Now, the K030 billable up to 4 times per year at $39.20. Once you complete that, you're going to bill your flow sheet, the Q040, for a total annual payment of $216.80 per patient with diabetes management. So that does add up quite quickly. So 121 to 141 patients is what we see on average based on 1,500 patient roster size. So that's anywhere from $26,000 to $30,000 in additional fee-for-service income. Now, if you add that to your average of $215 per patient in capitation, you're looking at $52,000 to $60,000 just for those diabetic patients. Smoking cessation. Anytime you have a patient come in for a cough or a cold and you happen to ask them about quitting smoking, you're going to add on the E079, and then twice within that subsequent year, you're going to bill the K039 and the Q042. Again, another way to generate income, about $100 per year in additional income for patients who are trying to quit smoking. Net access bonus. So a lot of people find this to be a little confusing or tricky, but all it is, it's a bonus paid based on the level of access you're providing to your patients. Every physician will start the year with a bonus potential. It's based on 18.59% of your total roster size. So approximately, based on the average roster size, each physician will have about $60,000 per year, broken up into two groups, April to September and October to March. Now, every time one of your patients, rostered patients, goes to a walk-in clinic, whatever is billed, so for example an A007, will be reduced dollar for dollar. So if you have 10 patients that go to a walk-in clinic at $33.70 per, that's $337 that's going to be reduced from your access bonus. Now, this happens on a monthly basis. It's calculated how many of your patients are going to walk-in clinics and how many patients are not. And it adds up, and we will assist you in making sure that this does not get below zero. Now, a lot of physicians in the first year of the FHO don't have access to this previously, so they don't know what their patients are like. They don't know what their habits are like, and frankly, it didn't matter beforehand in the FIG model, because it didn't matter if those patients were going to walk-ins and then coming to see you later that afternoon. However, in the FHO model, it does matter. Now, we don't want that to happen, so we have our outside use management analysis where we will assist you in identifying those patients and treating them accordingly, which we will get to in a few slides. Now, it's paid out based on group performance as well. So negative members do impact those that are positive. For example, if there was a group of 10 physicians and half the group was negative for $5,000 and half the group was positive for $5,000, it would equal out to zero and nobody would receive anything. So it really is a team sport when it comes to this, making sure that you're providing access to your patients as well as your fellow colleagues. So some of the challenges of outside use management. Frankly, it's hard to control patient behavior. We can't tell patients what to do. Well, we can tell them what to do, but we can't control what they do. We can tell them over and over and over again not to go to walk-ins or call here first. If it's more convenient for them, that's what they're going to do. But hopefully over time, they'll start to realize the pitfalls of going to the walk-in, you not knowing what's going on, them having to come see you anyways. Whatever the case may be, hopefully over time it does subside somewhat. Quite frankly, patients are just unaware of the impact. They just don't understand. So letting them know that it's costing taxpayers extra money, by paying the walk-in clinic and your family physician. The continuity of care is no longer there. You don't get a report of what's happening at the walk-in clinic, whereas if you came to see your family physician or one of the other FHO colleagues, you would get a report. You would have access to that. Not having open appointments during the day. That is really key to cutting down outside use, leaving those spots open and letting the patients know that you have those spots open, having posters up in the office, outgoing phone messages, your answering machine to let them know that they have to call in, that there are appointments available. And patients are unaware of the after hours. Being in the FHO model, you're required to do after hours services during the week, depending on the group size. Will depend on how many you have to do, but they're just unaware that that's available to them. So letting them know that they are able to come after work with their children or by themselves, whatever the case may be, letting them know that you are there. And of course your referral patterns as well, knowing who you're referring to. There are a lot of GPs in the community that are providing focused practice services such as psychotherapy or sports medicine or addiction or allergy treatments, diet clinics, all these things. If they don't have that focused practice designation, those will be billing in-basket services, and that will affect your outside use and access bonus. So knowing who you're referring to is very important. So about what we do to mitigate outside use. We have proprietary software to determine what patients are going outside and what their patterns are and what they're going for, how often they're going. We analyze this data on a regular basis and let you know who is going and at what point it makes financial sense to move them from the roster to the fee-for-service bucket. Again, educating. We'll help you educate your patients on what it means to be in a FHO, and ensuring that the key messaging is being delivered by physicians and staff. A lot of times we don't think that the staff play a key role, but in fact they play a very important role in the office. They are the frontline workers for you. They have that interaction with the patients. They're the ones speaking to them on the phone. They're the ones taking the appointments. Having them understand the whole program is really important. So here are two snapshots from our outside use management analysis report. On the left, you'll see what codes are being contributed to outside use. We'll always give you a breakdown of the percentage of codes that are being utilized. It's the K codes that we really want to try and avoid, those high dollar value codes. And what days of the week are being utilized outside the clinic. So, for example, if it happens to be Tuesday that spikes really bad for you, leaving those extra spots open on Tuesday, even on Monday, because people call in Monday, they can't get in, they can't wait, they're just going to go to a walk-in the next day. So we'll help you transition and make sure that you're aware of the different patterns and trends within your patient population and help you assess what needs to be done. So here you can see a breakdown of a list of 20 patients from our outside use report. We will always provide you a list of 20 patients. That's not to say that you need to de-roster all 20 patients. Our rule of thumb is anyone greater than 100%. So you can see on the right side there's a return column. Anyone over 100% means that you're losing money by having them on the roster. So here you can see we're comparing the income versus cost. So when I say you're losing money, it means that the income you're earning in the green column there, the prorated capitation, is far less than your outside use during the reporting period, which is 6 months. So as you can see, the for the first patient there, first had $582 of outside use over a 6-month period, but we only earned $85 for them during that 6 months. So clearly there's a huge gap there, and we want to de-roster that patient as soon as possible. Now, how do we know when to de-roster? So by looking at the frequency, how many months it's been incurring, what services are being utilized as well. If it's something that's an A007, we might want to talk to that patient before de-rostering. However, if you can see that they're going for nerve block treatment or psychotherapy or home visits, those are the patients we want to get rid of right away. And as well, we want to de-roster back to the earliest date of outside use. As you can see right in the middle there, we will provide you with the date that the outside use started to occur. Now, when you're going to send in the de-roster form, ensuring that you put that date is key, because when you de-roster back to the earliest date of outside use, you will get back all the outside use dollar value that was incurred. You'll give back the capitation for that period of time, but you'll also be topped up full fee-for-service value for any visits that were had during that time. So at the end of the day, it's a net benefit for you to de-roster back to the earliest date of outside use. So let's talk about special premiums now. So special premiums, as I said earlier, there's $37,000 that's available to you across 8 different categories. As well, there's CMEs credits that are available to you at a total of $2,400 or 24 hours per year. Now, here you can see the 8 different categories. In the blue, you'll see what's available in addition in the FHO model. So there's hospital work that's available, there's office procedures, and there's prenatal care that's available to you once you make that transition from the FIG to the FHO model. Now, we're not going to tell you to start providing care in all those services, in all those areas, but chances are we've seen a lot of physicians that actually do provide office procedures without even knowing it. Wart removals, stitches, things like that, ear syringes. A lot of the physicians already provide that care, and they just don't even realize that they can get compensated for it now. And then, of course, prenatal, if you have any pregnant women in the practice, you'll be able to receive that. So let's talk about a little bit of a case study now. So a little background. Back in 2012, we had a group of physicians out in Whitby that started working with us, and they wanted to transition from the FIG to the FHO model. Their motivation was to increase income, have a better work-life balance and flexibility, and optimize their outside use and access bonus. Now here you can see their goal, their number one goal was to transition to the FHO model within a 1-year period. Now what did we do to help that? We worked with them to optimize their FIG in preparation for the transition, and we led all ministry required documentation. That's to fill out all the applications, the back and forth, signing it, making sure that it's being sent off on time. If you want us to do your banking, opening the bank accounts, making sure that the scheduling is in place, all of those things come into play. It really does take a lot behind the scenes to get a FHO up and running. The outcome was that they did transition successfully within their desired timeline. Now they also wanted to stabilize their access bonus within a year, and they wanted to highlight the chronic contributors, which we did. They wanted to do patient education and outreach, which we did. Now you can see below their capture rate at the beginning when they started. They started end of 2012. So within that first 6 months or 9 months, it was quite low because they didn't have that visibility beforehand, and it did take them quite some time to educate their patients. But as you can see, we started at just below 0, -2%, give or take. By January 2014, we were up at almost 40%. So it really does take some time to educate your patients and get a full understanding of how the Access Bonus program works and to really maximize on its benefit. So some of the goals overall as well is to finalize the FHO governance agreement, which of course we helped them structure and we helped them draft. And of course we made sure that it was all signed in a proper timely fashion. They wanted to increase their special premiums and bonuses. Again, we made sure that we showed them what bonuses were available to them, how they were performing in each of those categories. We were able to identify over $100,000 available to them within all the doctors that were working with us. Optimize FHO administration, banking, and scheduling. We took over the administrative requirements for the FHO operations. Again, we made sure that all the applications are in, anytime there's a locum application, any of those things. And of course the banking. The banking really does take a lot of time, making sure that everyone is receiving the proper amount every month. We have a dedicated team of accountants and a financial department that works on this every day for all our FHOs. So it really does take a huge burden off your shoulders. As you can see, we delivered 48 hours per month of operational support, still ongoing. We provide ongoing assistance and maintenance for staff and physicians. Like I said earlier, making sure that the staff are aware of the whole program and what they need to do is extremely important. Like I said, they are the frontline staff. They are the ones that are the face. They are the ones that are dealing with the patients on a regular basis by booking appointments and scheduling and things. So it really is important that we educate them on what it means to be in a FHO. A lot of times we find that, yes, they are great staff, but they just don't have the full education, the full understanding of what needs to be done. So we delivered about 5 hours per month through Cirrus Helpline. We are always here to help. Both staff and physicians are allowed to call us and encouraged to call us with any question they have, big or small, regardless of what it is. We want to be there to help you. So physicians increased income by approximately 120% after the transition. Being in the FHO, you have a greater handle on how to deliver high-quality patient care without dramatically shifting your practice style. Now, we want to make sure that you maintain your practice style, what's comfortable to you, but again, you don't have to work as hard being in the FHO model. We want to make sure that you're being optimized and working efficiently. We want you to work smarter, not harder. So some of the key takeaways for today. For our FIG members, review the bonuses you are eligible for in the FIG, those 5 categories, and ensure you are billing effectively for them. Ensure that you're rostering patients in the FIG to allow for a smoother transition to the FHO model. As I said, the roster is the most important aspect of being in the FHO, so making sure that you have that roster built up is very important. And then set up a preventive care program within your practice to maximize bonuses available to you. As I mentioned, $12,800 across the pap smear, the mammogram, the flu shot, the childhood immunizations, and the colorectal screening. Very important. And for our FHO members, consider transitioning to the FHO for income predictability, flexibility, rewards for offering complex care to patients. Be aware of outside use. It's a daytime access issue, not on the weekends because they can bill the 888. We want to make sure that we're providing that daytime access Monday to Friday. You have the ability to deroster retroactively. As I said, you go back to the earliest date of outside use. You return all the money that's been incurred for outside use. You have a net positive position. So that brings us to the end of our presentation for today. I thank you all very much for joining us. If you logged on late, or if your colleagues weren't able to join us, we will have a recorded version of this presentation available shortly. I'd be happy to send it to anyone who is interested. You can contact us both at the Cirrus Helps email, myself directly. My contact information is there. Please reach out with any questions or concerns you may have. If you're looking to optimize your FHO, if you're looking to transition from the FIG to the FHO, we'd be happy to run some analyses for you to make sure that it is the right decision for you. And again, ongoing support that we provide is to both staff and physicians, and no question is too small. So again, thank you very much for joining me today, and I look forward to speaking with all of you very soon.